All right, okay, good. That's the recording started. Okay, so I hope everybody can see me and hear me. As I've just explained, a little bit odd this morning. I'm in the car because I'm teaching at the uni this morning. I don't have an office there. Anyway, right, today. So this is kind of me back to square one, back to the beginning. Okay, so if you've just joined us this morning, this is an excellent place to start. If you haven't just joined us this morning, this is me back to basic, starting off with cardiovascular disease. Okay, so what I'm going to do today, this is cardiovascular disease, the basics. So we're going to have a chat about what cardiovascular disease is, and then I'm going to cover the modifiable and non-modifiable risk factors, okay? And then lots of the Wednesdays after this will be covering the individual modifiable risk factors, okay? So that's where we're going to go from today. So it's kind of the start of the 15-week block, for want of a better word. So if you've caught me the last couple of weeks and there was things that were quite confusing, don't worry, we will cover those over the next few weeks. And if you've listened to this before, I apologize. What can I say? Okay, so cardiovascular disease. What are we talking about when we're talking about cardiovascular disease? So it's really a term. Cardiovascular disease encompasses a general term for conditions affecting the heart and blood vessels. So you've got your heart, which pumps blood all around the body, and it pumps it out into arteries, and then the blood returns to the heart via veins. Okay, so that's your cardiovascular system. Cardiovascular disease are the conditions that affect this system. Okay, and it's usually associated with the buildup of fatty deposits in the arteries. All right, and the technical term for this is atherosclerosis. Okay, I'm happy enough with fatty plaques. Okay, this does not have to be technical at all, but atherosclerosis, and that results in the increase of blood clots or blockages in the arteries, which can damage the arteries in your brain, your heart, your kidneys, and your eyes, etc. Okay. Cardiovascular disease is the main cause of death and disability in the UK. Okay, which is quite scary. But the good news is it's preventable. All right. It's not a done deal. So types of cardiovascular disease, because it encompasses lots of different diseases. The first one would be coronary heart disease, we would think of. And so essentially I've taken my students this morning for a lipid lab, and I'll explain to them, your heart is literally the size of a fist, okay? And it's got 3 big arteries that wrap around it. And your heart pumps the blood to the rest of the body, but your heart also needs blood. So these 3 big arteries supply your heart with blood. And the 3 big arteries take blood, which has got oxygen and nutrients, to the heart muscle. When you have a decrease in blood flow, if there's a partial blockage or a complete blockage where you have a complete stoppage of blood flow to a certain area of the heart, if the blood flow stopped, you're not getting oxygen to the blood muscle. And that's when you put more strain in the heart. So if you've got a kind of semi-blockage or not completely blocked, that will present as a symptom where you get chest pain. Does anybody know what the technical term for that is? You may have heard this if you have anybody in the family that suffers from heart disease. There's a term that you get chest pain, and it's kind of usually a sign that you may be en route to having a heart attack.
Is it angina?
Angina?
Yes, angina. Excellent. Okay. And angina, scary as it may be, is a good thing, I would suggest, because it's a warning shot. Because some people don't have angina. Some people just literally drop of a heart attack. All right. But if you get angina, at least you know there's an issue and you can have that investigated. Okay. So angina kind of can.
Estimate yourself, and I'm not going to listen to I'm not able. I'm not fit. It's not true.
Sorry, can I just ask Pamela? Could you? Yeah, thanks. Sorry. Okay. So basically, if there's a increased strain in the heart, there's a lesser supply of blood and oxygen getting to a certain area, you can get angina, which is this chest pain. And if there's a full blockage and there's no oxygen getting to a certain part of the heart, that will be a heart attack. Okay. And that's, in medical terms, that would be, you may have heard of an MI or myocardial infarction, and that's just a heart attack. Okay. And then after that, what can happen is if you've got angina or you've had a heart attack, the sequelae of that, or what can result from that, can be heart failure. Okay. And heart failure is one of those things, even as a medical student, you probably didn't think, oh yeah, but somebody survived their heart attack and heart failure is not that big a deal. Heart failure in the end stages can be as bad as some cancers, okay? It's a really awful thing to live with, not being able to breathe properly and having to sit up, not being able to lie down properly. So it's a really important comorbidity of having, you know, angina or having had a heart attack. Okay, so that's the heart, and that's the one that most people know about in terms of having problems with buildup of fatty plaques in their arteries. The next thing that's really important, or as important, are strokes. Okay, so that happens when you have the same problem in your head. So essentially, you've got two big arteries that run up the side of your neck, and these branch off, and you've got arteries all over your head that supply your brain with blood. And a stroke occurs when the blood supply to the brain has been cut off. So it's the same process as what's happening in your heart. There's a blockage, and that results in a decreased blood supply to a certain area of your brain, and you can get brain damage, or it can lead to death if the stroke is a big stroke. All right. Now, again, you can have a warning shot before a stroke. So before you have a heart attack, you can have angina that lets you know there's a problem with your heart. You can go and get investigated, get treatment, etc., etc. There's also a little warning shot for having a stroke as well. Does anybody know what that's called?
Is it the TIA?
Yeah, so TIA, or a mini stroke. So a transient ischemic attack. And the difference between a mini stroke and a full-blown stroke is that any of the things that happen to you, the sequelae, so basically things that happen to you in a stroke, so arm weakness, slurred speech, or confusion or whatever, that has to resolve within 24 hours. If it resolves within 24 hours, it's a TIA, a mini stroke. If it goes on longer than 24 hours, you've had a stroke. All right. And the main symptoms of stroke include facial droop. Limb weakness can be your arms or legs, usually at one side of your body, and plus or minus slurred speech. But there are lots of different things, and we will cover strokes in more detail in a different session. Okay, anybody get any questions about heart attacks or strokes? Nope, everybody okay? Stunned silence. Right, okay, so one of the other things that you can have with cardiovascular disease is what we call peripheral vascular disease. So lots of people have heard of heart attacks and strokes. Peripheral vascular disease, probably not so much. And it's the same, again, it's the same process. So when you've got a big artery that comes out of your heart called the aorta, it comes out of the top of your heart and it bends and goes down the middle of your body. So it goes down your chest and down your abdomen, and lots of vessels branch off from this to supply your kidneys and your gut to make sure they're okay in terms of blood supply, etc., etc. When it gets to your pelvis, this big aorta bifurcates into two big arteries, your femoral arteries, and they run down your legs, okay? And again, there's lots of vessels that run off. Now, when you get this buildup of fatty plaques and atherosclerosis in your legs, that results in something called peripheral vascular disease. And again, you get warning signs before there's a complete blockage. You'll get something called intermittent claudication. Again, quite a fancy term, but essentially this is just when you're out walking. So you may have been able to walk for quite a few miles before, and then as you get older or your peripheral vascular disease progresses, you'll find that you get cramping in the back of your legs. And you'll often see older men out walking with this, and they'll go so far, and they'll be in a park or whatever, and they'll sit down in a park bench and they'll rest for 5 or 10 minutes. The cramping goes away, they can get up and they can start walking again. And if they get referred, if they have this cramping pain that's intermittent, and then as the disease progresses, you can start to lose hairs in your leg and feet. Your feet may become cold. It's essentially because your blood supply to your legs isn't as good as it was, because there's, you know, furring up of your arteries. And then you can get pain overnight at rest, and that means the disease has progressed. And when you go to a clinic, either your GP or you get referred to the vascular surgeons, they will ask, how far can you walk in the flat? You may have said, oh, well, I used to be able to walk, you know, a kilometre. I can only walk 500 metres now, or, you know, 200 yards or whatever, and that's getting less. And that shows you that the disease is progressing. And again, the vascular surgeons have several tests they can do to have a look at the pressure in your legs and the flow of your blood in your legs. Again, it's the exact same process that's happening in your heart and your head is happening in your legs. And indeed, there are people who've got severe cardiovascular disease, and the fact they've had a heart attack, they may have had a stroke, and they have problems with their legs. and they have got are known as arteriopaths, okay, because it's affected pretty much all their vascular system in their body, okay. And then there's one other disease that's also included in cardiovascular disease. I'm not going to chat about this a lot, actually, because it's not as common as heart attacks, strokes, etc. It's aortic disease. So this affects the aorta, so that's the biggest artery in your body. Carries blood from the heart to the rest of the body, and you can get aneurysms of this, okay? And that just means you've got a weakness in the wall. Aortic aneurysms are usually asymptomatic. You usually don't know about them, which is the really dangerous thing, okay? Because if they burst, then you can get life-threatening bleeding because it's the biggest artery in your body. But I'm not going to say anything more about that because it's not really in the remit of this chat, okay? So that's essentially cardiovascular disease, heart attacks, strokes, peripheral vascular disease, and aortic aneurysms. All right, anybody get any questions about that? Because I'm now going to move on to the causes of it, what causes all these things. Nope, everybody happy enough? Good, right. So the cause of cardiovascular disease is not exact, well, it's not the exact cause is unclear. That just means I would suggest that there's lots of different cause, there's not one single cause for cardiovascular disease, so that makes it complicated. And there's still lots and lots of research going on trying to determine how it all starts, I guess. But we do know, even though we don't know the exact mechanism per se, and they're still working on that, we do know about risk factors. Okay, so this is what we work off in clinic, because that essentially, the more risk factors you have, the greater your chances of developing cardiovascular disease. Now, in clinic and with my medical students and also in clinic, I chat to patients about modifiable and non-modifiable risk factors. So the non-modifiable risk factors are important to know about, okay, because they're involved in risk stratification, but they're a done deal. They're non-modifiable. You can't do anything about them. So can anybody give me an example of what they think would be a non-modifiable risk factor? Something I will ask about, but you won't be able to change.
Your genetics.
Okay, yep. So genetics, your family history, yep, your genetics.
Your age.
Age, yeah. Age is really important. And age is really important in risk stratification. If you use any of the risk calculators online to look at your cardiovascular risk, the older you get, it doesn't matter what the other parameters are that you put in, your risk is going to increase. And it's quite straightforward. You're more likely to have a heart attack or stroke at the age of 80 than you are at 20. It's as simple as that, okay? You just are. Okay, so age is a non-modifiable risk factor, but your age is your age. You can't do anything about it, okay? Genetics as well, okay? Anything else?
Other health conditions?
Yes, but they may be modifiable, I would suggest, in terms of, so an example of another health condition would be diabetes, okay? But it depends how well your diabetes is controlled. But yes, I see where you're coming from, but that's not seen as one of the 4 non-modifiable risk factors. Sex is one of them, okay? Whether you're male or female. And by that, I mean XX or XY, okay? And the reason for that is we know men get cardiovascular disease about 10 years older than or before females do. Men, if they've got an increased risk, will get it 10 years earlier than us, but then we surpass them when we go through the menopause. Whoop, whoop. Just another insult to injury when you're going through the menopause. And I'll cover that in a session when I do the menopause about metabolic risk and cardiovascular risk going through the menopause. And the other one is ethnicity. Okay, so your ethnicity, and the reason why your ethnicity changes your cardiovascular risk is because you've got an increased risk of high blood pressure, type 2 diabetes, etc., at a different body habitus with different ethnicities, okay? And it's all got to do with how we lay down fat, etc., depending what our ethnicity is. And again, I'll cover that later on. Okay, so those are your 4 non-modifiable risk factors. They're all important. I need to know whether my patient is male or female, what age they are, what ethnicity they are, and their family history or genetics. And the genetics I would probably ask about would be, do you have a family history of heart disease? We'll come back to that, or a family history of high cholesterol. Okay, so we're now going to move so in terms of
Watch it on the
age, more common in people more than 50 years of age. Okay, I'm not saying heart disease doesn't happen in people under 50 years of age, and you'll probably all know someone who's had problems with their heart before the age of 50, but it is more common, and that's essentially because it takes quite a few years for things to build up in terms of blocking up your arteries and things like that. Okay, and yeah, it's more common in people more greater than 50 years of age, and females' risk increases when they go through the menopause. In terms of sex, guys are more likely to have cardiovascular disease at an earlier age than females, but again, it's coming to light now that it is a real problem for females. If you ask anybody, okay, well, I'll ask you guys, what do you think is the biggest health concern for females? Just off the top of your tongue, what's the thing that probably scares you the most? Because I know what scares me the most.
Oh, females.
Let me just.
Cancer, probably breast cancer.
Yeah, breast cancer, okay. Cardiovascular disease in females is way more of an issue health-wise than breast cancer is. Something like 5 times, all right? Now, that's not belittling breast cancer, but what I'm trying to say is cardiovascular disease in females is really important. And it's something that we've kind of thought as being an older man's disease up until now, and it's not, okay? And definitely when you go through the menopause and things change from a metabolic point of view. Okay, so cardiovascular disease is something that females should be really aware of, all right? And it shouldn't be put, below the threat of a cancer or a health concern in front of cancer, okay? Because it's not, it's the number one cause of death and morbidity and mortality in the UK, all right? So ethnicity is also important, non-modifiable. Cardiovascular disease is more common in people with South Asian, African, Caribbean backgrounds. And again, these patients are more likely to have an increased blood pressure and type 2 diabetes, and that all increases your cardiovascular risk. All right. In terms of genetics, family history of heart disease, what am I looking for in clinic? I'm looking at having a family history of heart disease under the age of 60 for a first degree relative. Okay, so that is first degree is your mum, dad, and your siblings, your brothers or sisters. Second degree is your grandparents, etc., etc. So it's important if you have a first degree relative under the age of 60, but a second degree relative, so your grandparents would have to be under the age of 50. I get patients sent all the time, and I practice in the west of Scotland. Heart disease is rife. Okay, so most patients' parents will have had some kind of event at some stage, but if it's over the age of 60, it's not felt to be due to genetics. Okay, now I can still have people who have a heart attack at 50, but they've smoked 20 a day for 30 or 40 years, and etc., etc. So it's not a done deal just because they have the heart attack at 50 that it's genetic. But if your mum or your dad had their first heart issue at 70, it's less likely that you have a genetic component to it. Okay, and that's quite important. So the cutoffs to think of are 60 for a first degree relative and under 50 for a second degree relative. All right. And it's important to tell your family physician if you have a family history. They should definitely be asking about that if you're getting screened for heart disease. Okay, so we're now going to move on to modifiable risk factors. So I think it's 6 of these that I commonly think of. Oh, no, possibly 8 actually. Okay, so let's think of some modifiable risk factors.
Obesity.
Yes, weight. Okay, and it's not just weight, but it's where you have your weight. It's weight around your abdomen. Okay, and we'll come back to that in further sessions, why weight around your abdomen is important. Okay, weight's one of them.
Stress.
Stress is one of them as well. Yep, stress is very important. Chronic stress, as opposed to you've just been in a road traffic accident stress. Okay, that's a stressful situation. I get that, but it's more chronic everyday stress. Yep.
Alcohol.
Alcohol, yes. Yep.
Smoking.
Smoking, yes. Smoking's a big one when it comes to heart disease. It's funny, smoking is, in terms of heart disease, probably has more of an effect on heart disease than weight does. All right. Alex and I have to agree to disagree on that one. But yeah, smoking clogs up your arteries. All right. And smoking in terms of peripheral vascular disease is a no-no. If you get anything done to your legs or, you know, any intervention, or if you're diagnosed with peripheral vascular disease and you do not stop smoking, you will really struggle. Okay. Smoking affects your legs more than anything else. All right.
Lack of exercise?
Yeah, so sedentary lifestyle, or as I said to my students yesterday, sitting on the sofa, gaming too much, I would suggest, where your forefinger and your thumb are the only muscles that are getting used. All right. Okay, yep, sedentary lifestyle, good. Anything else?
Cholesterol.
Yes, cholesterol, yep. That's a very important one. Anything else?
I'm going to put diabetes in there as well.
Yep, diabetes is a huge one. Good. And the other one I have, which is very big, is blood pressure. Yeah. Okay, so those are all the things that I will ask my patients about when they come to clinic. I will have had their blood pressure when they come into clinic. We will have had a chat about blood pressure. So it's an incredibly important risk factor for cardiovascular disease, especially in stroke. Okay, and why? We'll do a session on blood pressure, but it's important because high blood pressure is basically just your blood being squeezed through your arteries at a higher velocity with more force. Okay, and if that happens, it means if there's any damage to the inside of your artery lining, it becomes more turbulent. Okay, the higher your blood pressure is. And if you have some fatty plaques and they have a fibrous cap which is calcified on them, and you've got turbulent flow that goes through your arteries, and the flow's higher under higher pressure, and that results in one of the plaques rupturing, that's when you can set off the whole cascade to have your heart attack or your stroke. So that's why blood pressure is incredibly important. And it's why blood pressure is one of the main targets for people who've had strokes before, have had heart attacks before, and have diabetes, to make sure that their blood pressure is well controlled. Okay, really important. Okay, smoking. Again, I think blood pressure and smoking are probably up there in the top two. Okay, smoking, really important in terms of heart disease. And again, it's because the laying down of the fatty plaques, and I will cover this again when we're chatting about, when we're doing the cholesterol session. The bad cholesterol, LDL, that is laid down in your plaques, that process of being laid down in your plaques is accelerated by smoking. Now, lots of patients will know about smoking and lung disease, but I don't think people have really made the connection between
storytellers from 33 different countries all around the world, and
okay, so I don't think lots of people haven't made the connection. They've made the connection between smoking and lung disease, but they haven't made the connection between smoking and heart disease and peripheral vascular disease. All right. Cholesterol, okay, quite obvious. Cholesterol is, the LDL cholesterol is the one that results in narrowing of your arteries. Okay, so that's what happens in heart disease. Increases your risk of blood clots, and that's when you have your heart attack. Okay, so somebody mentioned diabetes. So briefly, and again, we'll cover diabetes in separate sessions. There's type 1 and type 2 diabetes. Type 1 diabetes is when your pancreas can't make insulin anymore, autoimmune disease, that is a done deal. And then you've got type 2 diabetes, which is different than that. That's due to insulin resistance. However, both of them, no matter why they happen, result in your blood sugar being higher. That's the definition of diabetes, having a high blood sugar. Okay, and this high blood sugar, basically the sugar binds to lots of different things in your body, most things in your body, and the high blood sugar damages your vessels, and it can damage large vessels in your heart, and it can damage in your brain, and it can damage smaller vessels in your legs and in your kidneys and your eyes, etc., etc. So that's why, if you're a diabetic, good control of your diabetes is very important, because it increases your risk of cardiovascular disease. And indeed, diabetics don't usually die of diabetes. They die of heart disease and chronic kidney disease. Okay. Inactivity, or being sedentary. This is where these all kind of tie in together. So you've got a list of 6, 7, 8 things at the moment in terms of modifiable risk factors. But if you undertake no or very little exercise, that can result in increased blood pressure, can affect your cholesterol because it affects how your liver metabolizes your lipids, can affect your weight, and increased blood pressure, increased cholesterol, and increased weight all increase your cardiovascular risk. All right. Exercising regularly, cardiovascular exercise works your heart and your arteries and keeps them more supple and keeps your heart's a muscle, needs to be worked like any other muscle. Okay. So, and exercising regularly can also help you maintain your weight. Okay. Which moves nicely on to overweight being a risk factor for heart disease. So if you're overweight, this can result in increased blood pressure. It can increase your risk of insulin resistance, which is the step before being a type 2 diabetic. Both of these increase cardiovascular disease. Being overweight also puts your heart under more strain, because being overweight, you have to carry, you're carrying more body weight and your heart's having to work harder to get blood all the way around your body. And the biggest, the really good test for this is Alex often does this challenge where he asks whatever you've lost in weight. So if you've lost 5 kilograms, 10 kilograms, 2 kilograms, put it in a backpack, put it in your back and go up and down the stairs a few times and see how much more effort you have to put into that. Okay. And it's incredible when you carry the weight that you've lost in your back or wherever, you put it in a couple of bags and you just carry it, because look at how much more your heart is having to work. You know, your heart's pounding harder, you're out of breath easier. And that's what your body and your heart and your lungs were doing naturally, because that's what weight you were before. So it's a really good test to just show the strain that weight does. And the weight also, and we'll do this over the next few weeks, changes, if it's around your abdomen, changes how your liver works, how it is involved with producing cholesterol, etc. And the liver, and having a fatty liver results in insulin resistance, type 2 diabetes, etc. So it's all related. Diet's also important. Nutrition is important. So the two main things in your diet would be saturated fat. Now, 30 or 40 years ago, there was a big thing about fat being associated with heart disease. There were quite a few studies. Everybody jumped on the bandwagon. And this basically set many dietary patterns for forever by the looks of things. It was partly right. It was also partly wrong. It's not all fats. So saturated fats can affect your lipid profile and heart disease. But not all fats are saturated. So for example, the fats in olive oil, nuts, avocados, etc., and oily fish are not associated with an increased risk of heart disease. It's the saturated fats that are associated with that. But as a result of everybody getting told not to eat fat 30, 40, 50 years ago, what did everybody start to eat? Carbohydrates. Okay, so carbohydrates. Now, again, carbohydrates are not all the same. We all started to eat refined carbohydrates. All right. And when we eat refined carbohydrates and we have replenished our muscle and liver stores of glucose, because essentially refined carbohydrates are broken down into glucose very easily. The excess glucose stored as glycogen, once we've restored our glycogen stores, which is how we store carbohydrate in the body, the glucose just gets converted to triglycerides, to fat. Okay, and here lieth the problem, because this is why we get fatty livers and put on weight, because we're storing our fat or our excess calories essentially as triglycerides. Okay, and that increases your risk of cardiovascular disease. All right. And then finally, alcohol. What can alcohol do? Lots of things I would suggest. So excess alcohol can affect your liver, which will affect your lipid metabolism. So it can increase your cholesterol and your triglycerides. And don't worry if you haven't heard of triglycerides before. Lots of people haven't heard of triglycerides before. I will cover that in another session. 9 times out of 10, my patients have all heard of cholesterol, but they haven't heard of triglycerides. So don't worry, we'll do a session on triglycerides. But it's just another lipid in your blood that's important in terms of cardiovascular risk. Okay, so alcohol increases your cholesterol, triglycerides, because it can affect your liver, increases your blood pressure, and its calorie intake. Alcohol also has a calorie burden. All right, and it also, if you drink excessively for quite a while, you'll actually get something called cardiomyopathy. You can make your heart big and floppy, which isn't good. There are genetic causes of cardiomyopathy, but you can actually get there as well just by drinking. I can't think of an organ in the body that alcohol doesn't affect. Okay. It's I was going to say it's that good or it's that bad, should I say? Okay. Right. So that's a lot of doom and gloom for a Monday or for a Wednesday morning, I would suggest. However, the good news is, what's the good news, do you think?
We can change some of it. We can reduce our risk for some of those factors.
Yeah, because more factors are modifiable and non-modifiable, we can do something about it. Okay. So as Alex said, I've got this written up on my whiteboard in my gym at home. I can't guarantee tomorrow, but I can definitely improve my odds. All right. You know, I can't guarantee, and it's the same in clinic. Patients often say, "Oh, what about X, Y, and Z?" And I'll say, "I don't know whether you're going to have a heart attack or a stroke tomorrow. I don't know whether I'm going to have a heart attack or a stroke tomorrow. You know, I just don't." But by putting certain things in place in terms of lifestyle, I can definitely improve the odds in my favour or reduce my risk, depending which way you want to look at it. Okay, so cardiovascular risk reduction. What are we going to do based on all the modifiable risk factors I've been chatting about? What are we going to do? Sorry, I've muted everybody just because.
Oh. No, it's me.
Get
I
up and
take time to
move.
find it.
Do some
Um,
exercise.
Yeah, exercise. Sorry, Sue, on you go.
No, I was going to say the same. Lose weight, improve your diet, do
Okay,
more
so
exercise.
yeah, so
Mm.
we're gonna improve our diet. So how are we going to do that? What are we going to do in terms of diet?
So cut out the more of the saturated fats and the refined carbs, or reduce those.
Yep, excellent, good. So we're going to decrease our saturated fat. We're going to decrease our refined carbs. We want to increase our fruit and veg. Yeah. So we want to eat the rainbow. I would say brown, not white. So if you are going to eat whole grains, make sure they're brown, whether it's bread, rice, pasta, whatever, make sure it's brown, but those in lower quantities. Okay. And we want to increase our fiber. All right. So that's really important. So two simple things, two little things I like to think of: brown, not white, and eat the rainbow. That covers a lot of stuff just in those two little quotes. Brown, not white, and eat the rainbow. That covers a lot of things, which is really good. Another thing from your diet you need to be careful with is salt, and I'll cover that when we do blood pressure, okay? We don't need to add salt to anything. There is enough salt in all the processed foods we eat by far, okay? I think there's more than your daily recommended intake in a bowl of cereal, okay? And that's you only at breakfast, okay? So we'll do a little bit about that later on, but yeah, salt you have to be careful with, okay? And obviously sugar you have to be careful with. That kind of comes under the remit of the refined carbohydrates. I would also argue, since doing TSD, and I didn't do this at the beginning, but when I started TSD, I hadn't gone down this rabbit hole yet, but since I have gone down the rabbit hole, all about ultra processed foods, okay? I think we've really got to think about what type of foods we're eating, but I think if you kind of stick to a whole food diet with plenty of fiber, you shouldn't go far wrong. Okay, so weight loss. Somebody mentioned that, I think. Okay, so okay, this is a good question for this group. How are we going to go about doing that? Can I have somebody that maybe hasn't said anything?
Just follow the plan.
Follow the plan. Follow the plan. Okay, so if you were going to give your friend 2 tips for weight loss, what would you suggest?
I get lots of asking lately because I have sort of managed to lose a bit. So I just say it's a combination of exercise, watching, sort of monitoring intake and mindset, really. So
yeah, and Amelia said don't get hungry. That's really important. That's what I really struggled with to begin with, and I've changed what I eat now because I've adapted to what I do eat and how many times I eat during the day and the calories I eat at every meal. Okay, but to begin with, I was hell bent on making sure drinking more water. Yeah, that's a great one as well. So making sure you're not hungry. And how did I do that? didn't eat a lot of cheese before, but I probably had cheese maybe every day. I weighed out my first 20 grams of cheddar and thought, for the love of God, a mouse wouldn't even be happy with that, right? So I stopped eating cheese because there was no way on that earth that 20 grams of cheddar was even going to go anywhere near satiating me. Okay, not a snowball's chance. So at the beginning, very much so, I ate foods, and again, it's the whole foods, because you can eat, you know, your salad could be, or your vegetables could be, or whatever. I ate loads of foods to kind of pack around what I was eating to make sure I was satiated. So that's really important. So exercising is important as well. So basically moving. So there's lots of different types of exercise. There's your formal exercise. You can go to the gym. We all know why we're building muscle. Okay. You can run, you can swim, you can cycle, you can do yoga, whatever. One of the big things is your non-exercise activity thermogenesis. That is basically just moving during the day, not sitting on your butt. And that's probably more important. That's your 10,000 steps, making sure you hit your target, or your 5,000 steps, or your 2,000 steps, whatever it is, but building in that. It doesn't really matter where you're starting, just as long as you build in that. Cutting down alcohol. So UK government recommends 14 units per week. Know your units. Again, if your calories, looking at your calories, you won't be drinking a lot of alcohol, I would suggest, in this group. And if you are at high risk, it is important to take medication. So if you're at high risk, you may be on blood pressure medication, or you may be on medication to lower your cholesterol. That should all be continued unless the physician that's looking after you says yay or nay, or you can reduce it. There are people who've come off blood pressure medications and diabetic medications in this group, but you have to be aware, you have to do that under controlled when, your physician says so. All right. You need to be very careful with that, because when you're losing weight, your blood pressure may come down, but you don't want to stop your medication just because you've started your new exercise or, changing your nutrition. Because if your blood pressure is still high, you can have an issue with having a stroke or a heart attack, or et cetera, et cetera. Okay. So it's really important. And stop smoking. Okay. That's another one. Good. Excellent, Lynn. You've reduced your blood pressure medication significantly. That's fantastic. And those are the wins. I think those are the wins. And would I argue as a physician that that's probably more of a win than losing weight? Well, they kind of come hand in hand, I would argue, but it's fantastic when people come off medication, okay? It's really, really good. And it's a really good win to have. Right, so just to wrap up, I'm going to go over the fact that we've got cardiovascular disease. Affects lots of different parts of the body, can affect your heart attack can affect your head, strokes can affect your legs, peripheral vascular disease. There's modifiable and non-modifiable risk factors. Non-modifiable are important, but you can't do anything about them: age, genetics, sex, and ethnicity. Modifiable are more important just because we can do something about them, okay? And that includes your cholesterol, diabetes being well controlled, blood pressure, diet, exercise, etc., etc. And hopefully when you're going through TSD, you should be addressing all of these. So because they all tie in together. When your weight goes down, your blood pressure can come down. If you stop smoking, you'll be breathing better, which will allow you to do more exercise. If you reduce your alcohol, you're reducing your calories. You're also putting less stress on your heart, etc., and your liver. Okay, so I hope you've all enjoyed that this morning. Has anybody got any questions? Okay, lovely. Right, well, I will catch up with you next week again, and we'll continue along the cardiovascular topic. Okay, but lovely to see everybody this morning. Yeah, and hope you have a lovely week. Yeah. I hope the weather's better than mine. It's pouring down out here. Oh, but anyway, right, have a fantastic week, and I shall catch up with you next week.
Yes.
Thank you. Right, take care. Bye.
Bye.
Thank you. Bye.
Bye.
Bye.